Greetings, dear learners. We were learning the administration of antidotes under the management of poisoning. Under that, we learned classification of antidote based on the mechanism of action and the site of action. So, this is the broad guidelines under the management of poison, that is immediate restrictive measures, removal of unabsorbed poison from the body, removal of absorbed poison from the body, administration of antidote. So here we were. So under the administration of antidotes, based on the mechanism of action, we classified the antidotes as toxic effect bypass, inert complex formation, accelerated detoxification, reduced toxic conversion, receptor site blockade, and receptor site competition. Based on the mechanism of action, antidotes are mechanical or physical antidote, chemical antidote, chelating agents, serological antidote, physiological or pharmacological antidotes. We learnt mechanical and chemical antidote in the last class. Today we shall learn the chelating agents, serological antidotes, physiological or pharmacological antidote. Starting with the chelating agents. Chelating word is derived from the Latin word chela, which means the claw, because they grip the poison as if it is in their claw. You can see in this photograph, this metal ion is getting binded by the chelating agent, which is holding it like a claw, forming metallic chelates, and making it inactive so that it doesn't act on the body. So this is the basic mechanism behind the chelating agents. The chelating agents are the chemical that form the soluble complex molecules called the chelates with the metal ions, inactivating them so that they cannot react with the other elements. The important feature of the chelating agents are that they can act within the gastrointestinal tract as well, apart from the acting inside the blood. The chelation is a process where the chelating agent grips the metal ion or the atom like a claw of the lobster. The term chelate was first applied by the Sir Gilbert Morgan and SDK Drew in 1920s. The chelating agent molecule has the electrons available to form a bond with the positively charged transition metal ion. And so the chelators can be attached to the metal ion by two or more bonds forming a ring, which is called as the chelate ring. So with the metal ion, they form a ring around this metal ion. This is called as the chelate ring. The formation of the chelate ring is the hallmark of the chelating agents. The characteristic of the ideal chelating agent is that it should have ability to compete with the natural chelators, like the strong intracellular binding of the cadmium to the metallothionein prevents most chelating agent from removing it from the natural chelate agent. So they need to compete with the natural chelators like metallothionein so that it can take it out of the body. Then the complexes that is formed after the chelation shall be non-toxic complex. Then the distribution of the chelate agent shall be the same as that of distribution of a toxic substance or a metal, so that it will get in contact with the poison. Then it should have high affinity for the toxic metal but the low affinity for the essential metals that are already present and needed for the body. Otherwise, if toxic metals may take out the necessary micro metals that are essential for the body like zinc and other metals, so that it will be risky for the other problem may arise to the person. Then it should have a high water solubility as well as lipid solubility so that it can easily cross the cell membrane and bind to the metals within the cell. It should have minimum toxicity and the good absorbability from the gastrointestinal tract. And then after the formation of the chelate ring, it should have good rapid elimination from the body. So these are the ideal features that the chelating agent must possess to be a good chelators. Then coming to the different types of the chelating agents that are practically used and useful in different metallic poisons and different conditions. One of the most important chelating agent is the British anti-Lewisite or dimercaprol. British anti-Lewisite is a compound that was developed by the British at the Oxford University during the World War II. In World War II, there was threat to use of the vesicant gases, Lewisite and the mustard gases. Both combined with the sulfhydryl group found in the skin, of keratin part of the skin, and cause extensive tissue damages. To counter their action, British anti-Lewisite was invented, and it was seen to be useful as a chelating agent in the metal poisoning. From there, it started to be used as a chelating agent in case of metal poisoning, particularly mercury, arsenic, lead. You can remember with the mnemonic that BAL is used in MAL, mercury, arsenic and lead. So the important thing that we need to know about the British anti-Lewisite is that it has two unsaturated sulfhydryl group which combined with the arsenic rendering it ineffective. And it comes as a yellow viscous oily liquid with a disagreeable sulfurous odor. It is available in the form of the 3 ml of ampoules containing about 100 mg per ml of the British anti-Lewisite, and it contains additionally 200 mg per ml of the benzyl benzoate and 700 mg per ml of peanut or arachis oil. As it is oily, as with the content that peanut and arachis oil is added to it, so it shall be administered deep IM in the gluteal region specifically. So the important thing to be known is that it has to be injected deep IM in the body. It shall never be infused intravascularly because of the oily nature, it can cause fat embolism. As aqueous solution of British anti-Lewisite is easily oxidized and therefore unstable, so peanut oil is added to it so that it stabilizes the British anti-Lewisite. And then benzyl benzoate makes the British anti-Lewisite miscible with the oil. So benzyl benzoate and peanut oil are added to make a complete mixture for the practical use. The dose of the British anti-Lewisite is 3 mg per kg given every 4 hourly for the period of 48 hours and then twice daily for 10 days. British anti-Lewisite is primarily used for the mercury, arsenic, lead, but it is also useful in some other heavy metals such as bismuth, copper, gold, thallium and antimony. British anti-Lewisite is contraindicated in case of cadmium poisoning because of the reason that cadmium is primarily a nephrotoxic agent and British anti-Lewisite increases the uptake of cadmium in the kidneys, thus increasing its nephrotoxicity. Also, it is contraindicated in iron poisoning because British anti-Lewisite and iron complex causes severe vomiting. Then it is contraindicated in the methyl mercury, that is the organic mercury, because it causes redistribution of organic mercury to the brain, increasing the neurotoxicity due to the mercury. So it shall be avoided in case of methyl mercury poisoning. Then it is contraindicated in the liver dysfunction. Then the persons who are having the peanut allergies, because the peanut oil is already added along with the British anti-Lewisite. So the person having peanut allergy can produce anaphylactic reactions. Additional important thing that shall be kept in the mind while administering the British anti-Lewisite is that urine shall be alkalinized along with the injection of the British anti-Lewisite, because British anti-Lewisite and metal chelates dissociates in the acidic urine. So, the urine shall be alkalinized when we are using British anti-Lewisite. Then the person with the G6PD deficiency may cause hemolysis if given British anti-Lewisite. So, it shall be used cautiously in such patients. Then it may chelate out the essential metals in the body as well, like the zincs. So, it may have the deficiency of the essential features of the zinc metal. So, along with the supplementation of the metal, essential metal may be given if the problem arises, along with the British anti-Lewisite administration. Then the next chelating agent that we need to know is the DMSA and DMPS. Both of the DMSA, dimercaptosuccinic acid, and the 2,3-dimercapto-1-propan sulfonic acid, both of these are the British anti-Lewisite analogues. Dimercaptosuccinic acid, also known as succimer or chimate, was synthesized in England in 1949. Both DMSA and DMPS are the water and soluble analog of the British anti-Lewisite. They were primarily used for the mercury, arsenic and lead poisoning. That is same as the British anti-Lewisite. They are commonly used for the mercury, arsenic and the lead. Similarly, DMPS is also used for the mercury, arsenic and lead poisoning. It is very effective in combination with the edetate. So, the DMSA shall be given in combination with the edetate for the metal poisoning. DMSA has many advantages over the British anti-Lewisite or calcium sodium edetate. Recently, DMPS and DMSA are the best chelators that are considered by the most of the toxicologists, particularly DMPS. So, the DMPS can be given orally and it doesn't decrease the level of the essential trace metals such as zinc. So, the deficiency that arises because of the British anti-Lewisite are covered by the DMSA and DMPS, that it doesn't decrease the level of the essential trace metals like zinc. Then its toxicity is less, and also iron can be simultaneously given along with it. Unlike the British anti-Lewisite, where it chelates out the iron as well. It can be used in the G6PD deficiency as well, whereas the British anti-Lewisite increases the chances of hemolysis. So, it is overcoming all the disadvantages of the British anti-Lewisite. Even it is superior to the edetate in lead poisoning, as it does not redistribute lead to the brain. It can be used in methyl mercury also because of the similar reasons, as it doesn't cause redistribution of methyl mercury to the brain. Usually, the succimer is available as 100 mg of the bead-filled capsules. If the capsules cannot be swallowed, it is separated and beads are sprinkled over the juice or ice cream and then it is ingested. It is given in the dose of 10 mg per kg orally 3 times a day, that is 8 hourly for the period of 5 days at least, followed by same dose twice daily for the 14 days. This is no more contraindicated for the methyl mercury, iron or the G6PD deficiency cases. Then the DMPS, dimercapto-1-propan sulfonic acid, has almost the similar features as that of DMSA. It is also known as Dimavol or the unithiol. It is given in the dose of 5 mg per kg IV in the 6 divided doses, followed by 100 mg orally for 24 days. Then coming to the calcium sodium edetate. Calcium sodium edetate, that is also called the calcium disodium ethylene diamine tetraacetic acid or Veracin, is capable of chelating many metals like cadmium, cobalt, copper, iron, lead, mercury and nickel. But it is mostly used in case of lead poisoning. So for lead poisoning, calcium sodium edetate, British anti-Lewisite, mal, mercury, arsenic and lead. DMPS, DMPA, same as the British anti-Lewisite. That should be known to you. Then the important features of the calcium sodium edetate, EDTA, is that it combines with the lead to form a stable, soluble and non-ionized compound which is subsequently excreted in the urine. Calcium sodium EDTA increases the urinary lead excretion 20 to 50 times more. It is available in the 5 ml ampoules containing about 200 mg of calcium sodium EDTA per ml, and so that 5 ml will contain around 1 gram of calcium sodium edetate. Then disodium edetate should not be considered an alternative to the calcium sodium EDTA because of the risk of the life-threatening hypocalcemia associated with the disodium EDTA use. So the calcium is attached with the disodium edetate. That is the essential, because calcium, without calcium, it will cause the hypocalcemia in the body. It is usually given in the IV infusion, as it causes the severe pain on intramuscular injection. So it is given intravenously. British anti-Lewisite given the deep intramuscularly, DMSA given the orally, DMPA given injectable, DMPS given injectively, then the calcium sodium edetate given through the IV infusion. Then the dose of the calcium sodium edetate, so it is given in a concentration of 0.5% over 24 hours in a 5% dextrose or 0.9% of the saline. More than 0.5% concentration may lead to the thrombophlebitis, and so more than 5% concentration of the calcium sodium edetate shall be avoided. It is given in the dose of 25 to 35 mg per kg of the body weight in 250 to 300 milliliter of 5% glucose or normal saline over a period of 1 to 2 hours twice a day for 5 days. It is contraindicated in patients with anuria, hepatitis and renal diseases. In patients with a lead encephalopathy and cerebral edema, it may cause lethal increase in the intracranial pressure following the IV infusion. So, intramuscular route is preferred for these patients. Also, co-administration of British anti-Lewisite is useful where the IV route is necessary and the rapid infusion shall be avoided. Then another important chelating agent is the D-penicillamine, also called as the cuprimine or depen, is the metabolite of the penicillin, but it doesn't have any antibiotic properties as those of the penicillin. As you can see in the name itself, C penicillin, sillamine, C is copper, L is lead, M is mercury. So you can remember that this is used in the copper, lead and mercury poisoning. Important features of the D-penicillamine is that it is the D isomer, not the L isomer. As the L isomer of penicillamine, that is L-penicillamine, is toxic as it inhibits the action of pyridoxine and may produce optic neuritis, so it shall never be used. Penicillamine is useful against the copper, lead and mercury poisoning. In chronic exogenous copper poisoning such as Indian childhood cirrhosis, it may be given. In some non-toxic conditions like Wilson's disease, that is due to the disorder of the copper metabolism, cystinuria, rheumatoid arthritis and scleroderma, it has been found to be very useful in such conditions. Then it is given orally in the dose of 30 mg per kg of the body weight up to 2 gram per day maximum for the 4 times a day for 7 days of the period. Then it is contraindicated in certain conditions like aplastic anemia, agranulocytosis, because it can aggravate the aplastic anemia and causes agranulocytosis. Then certain cutaneous lesions may be aggravated by it. It aggravates the immune system dysfunction, renal and pulmonary diseases. So it shall not be used in all those conditions. Also, during the pregnancy, it is associated with the congenital abnormalities, so it is contraindicated during the pregnancy. About 25% of the patients who are allergic to the penicillin display hypersensitivity reaction to the D-penicillamine. So, those patients who are allergic to the penicillin, again they shall not be given D-penicillamine. Then another metabolite or another variant of the D-penicillamine is the N-acetyl D-penicillamine, also known as NAPA and NAPA. It is seen to be very useful in the mercury poisoning. It is given in the dose of 1 to 2 grams per day orally. It is used successfully in various poisoning incidences related to the mercury. One of the interesting incidents where this NAPA was used is the Basra poison grain disaster. Basically, the Basra poison grain disaster was a mass methyl mercury poisoning incident that occurred on the September 1971 in the Iraqi port of the Basra. A shipment of around 90,000 metric tons of the barley and the Mexican wheat that were intended as a seed grains were arrived in the port of the Iraq, then the Basra. The grains had been treated with the antifungal agent called made up of the methyl mercury to prevent it from the rotting. Although the grain was intended to be delivered to the farmers and had been marketed as a poisonous both by dyeing the grain with a pink color and with the warnings printed on the bags of it. As the warnings that were printed on the bag of those grains were only in the English and the Spanish. So, before it could be distributed to the farmer through a proper channel, the grains were stolen in a large quantity from the docks and sold as a food to the local population. As they could not read the English and the Spanish language, so they could not interpret it that this is dangerous to take. Then after around 2 years, that the Iraqis kept quiet for the 2 years, and it was not until 1973 that the American reporter uncovered the evidence of 6,530 cases of mercury poisoning treated in local hospitals. So, the Iraqi officials tried to hide this information and the incidence of the poisoning due to the methyl mercury. And finally, because of this reporting, Iraqi officials finally admitted that around 459 people died due to methyl mercury. But it was thought that there have been significantly more than this number. For the management of methyl mercury poisoning, in this Basra poison grain disaster, N-acetyl D-penicillamine was used extensively and proved very highly effective for the management. It was observed that it is equally effective as D-penicillamine, although less effective than DMPS, that is the 2,3-dimercapto-1-propansulfonic acid, that is also used in case of mercury poisoning, arsenic and lead poisoning. And as I already told you, that DMPS is observed to be superior than all the above chelating agents wherever they are being used. Then another important chelating agent is the deferoxamine. Deferoxamine is also called as desferoxamine B or DFO. It is an antibacterial siderophore produced by the Actinobacter streptomyces pilosus. It is useful in acute iron poisoning. The siderophores is basically the iron carriers that is produced. They are basically used by the bacteria to segregate the iron in their body. So the siderophores are the small high affinity iron chelating compounds secreted by the microorganisms such as bacteria and the fungi. They are among the strongest soluble iron binding agents known till date. Microorganisms secrete them to sequester the iron from the surrounding for their own use. On the same mechanism, deferoxamine works. That is, they sequester the iron from the body in case of acute iron poisoning and help in the excretion from the body. So the deferoxamine is available in the form of the deferoxamine mesylate, also known as Desferal. It is available in 2 vial sizes containing either 500 mg or 2 g of sterile lyophilized powder. On adding 5 or 20 ml of sterile water for the injection to either the 500 mg or the 2 g of vial respectively, results in a 100 mg per ml of the solution. It has to be given in the dose of 8 to 12 g per day orally and on parenterally as 1 g initially on the intramuscular route, followed by 0.5 g at 4th and 8th hour later, and then repeated every 4 to 12 hours as necessary. Total dose of the desferoxamine that is given is up to 6 g in 24 hours. Intravenous injection of deferoxamine shall be given only for the patients in shock at the dose of 2 grams in the 5% levulose solution given IV to bind absorbed iron, repeated 12 hourly, total up to 6 grams in the 24 hours. It is supposed that 1 mole of deferoxamine binds to the 1 mole of iron, therefore 100 mg of the deferoxamine binds to the 8.5 mg of the iron, and on this way we shall calculate the required dose in case of the iron poisoning. So these were the important chelators that we needed to know: British Anti-Lewisite, DMSA, DMPS, the calcium sodium edetate, penicillamine and deferoxamine. Then some other chelators that are available and are used is one of them is the pyroxidal isonicotinyl hydrase that is used for the iron poisoning. Also pyroxidal benzoyl hydrazone also used in case of iron poisoning, and deferriprone also used in iron poisoning. Then for nickel poisoning, diethyl dithiocarbamate DDTC. Then for thallium poisoning, the Prussian blue is the another chelating agent that is applied. Then one of the important is to know is the natural chelator known as the metallocyanine that is normally found in the living bodies. Although the exact function of metallothionein is not clear, but the experimental data suggests that metallothionein provides the natural protection against metal toxicity up to a certain extent. It was discovered in 1957 by Whaley and Maragos from the purification of cadmium binding protein from the horse renal cortex. Metallothionein is a family of the cysteine-rich, low molecular weight proteins. It is localized to the membrane of the Golgi apparatus. It has the capacity to bind both physiological, such as zinc, copper, selenium, and the xenobiotics like cadmium, mercury, silver, arsenic, heavy metals, through the thiol group of its cysteine residue. So, it may be thought that it is the natural chelators present in the body that helps in the protection up to a certain extent when the poison is taken in the body. So, with this, we finishes the chelating agents, and some of the remaining detail we shall take along with the different metal poisoning. Then, based on the site of action, another category of the antidotes are the serological antidote. We may also say it as immunotherapy. The serological antidote has derived from the serology, that is the study of antibodies in blood serum. And antibodies are part of the body's immune response to an infection. So basically, we are injecting a poison or a toxic substance into the body, another living body, and there the body naturally produces antibodies, and that is taken out and given to that is collected and preserved, and that is given to the person who has got poisoned with a particular toxin, so that if his body is not able to overcome on his own, so we are giving additional antibodies that will help to recover from the toxicity. So this is basic idea about giving this serological antidotes. So serological antidotes may be of different types, like they can be antivenoms, as in case of a snake antivenom. So a snake antivenom that is collected from the snake itself, that is the collection of the different snakes venoms. And then a scorpion antivenom. We will go in detail of them when we will be detailing or talking about the animal poisons. Then antitoxins like botulinum antitoxin, diphtheria antitoxin, where it is injected into the certain animal, and then from there we derive the antitoxin in the body, and that is used for the protection against the botulinum. Then anti-serum may be the anti-rabies serum, anti-tetanus serum, FAV therapy for the digitalis management, phenylcyclohexylpiperidine, and immunotherapy for the arsenic. These are all the agents that can be used as a serological antidotes. So when we use these antibodies to neutralize a poison, that is called as serological antidotes. Then coming to the physiological or pharmacological antidotes. Physiological or pharmacological antidotes works at the target cell by producing pharmacological effects exactly opposite to those produced by the poison, also known as dynamical antidotes. The important features of the physiological or pharmacological antidotes are that it works on the principle of antagonism, that it antagonizes the effect produced by the poison. Its effect is basically not complete but a partial. So, because of its limited use, it can be dangerous as well. It is only used when the poison has been absorbed inside the body. So, it works at the receptor or target organ level, not in the blood or inside the gastrointestinal tract. The important examples of the physiological or pharmacological antidotes are analeptics, that acts against the barbiturate. Barbiturate is a sedative, whereas analeptics are the arousing agent that causes restorative or strengthening are the arousing agent, which include proconvulsants like picrotoxin, strychnine, pentyl interazole, camphor, symptomimetics like amphetamines, methylphenidate, xanthine like caffeine, ethamivine, and non-specific stimulants like nicotinamide that is given in the respiratory depressions, bimegride, prectacamide, emifenazole. They were once recommended against the barbiturates, but they are no more recommended now. Then another physiological antidote is the amyl nitrite that is used against the cyanide poisoning. Then barbiturates, vice versa, it may be used against the analeptics like amphetamines poisoning, picrotoxin and strychnine. Then physostigmine is used against the atropine anticholinergic, and so cholinergic is acting exactly opposite to it. So in this way, this is about the physiological antidotes. So with this, we have covered all the aspect of the administration of antidotes. In the next class, we shall be going to the symptomatic management, and under that we will look about the syndromic approach to the management of the poison. With this, thank you so much.